When I'm attending, I use non-invasive blood pressure monitoring all the time, the automatic cuff on the LifePak 15. Before you come at me, of course, I auscultate the first one, and I confirm BPs that seem to not match the patient presentation. Just relax. Let me explain. It'll be quick. I'm Angry Bill, and this is pre-hospital wisdom. To me, the biggest benefit to using NIBP is that it frees me up to undertake other tasks. If there are no other tasks, it frees up my brain to think about the call. Contemplating the call, like what else could be going on and what else I may be missing, what else I could be doing, and those types of things. Secretly, how about what else could be going on? There should be another video like that around. Is one of the most significant tasks on a call. Paramedicine is about, after all, thinking. It's a mental exercise more than a physical one. I find, though, that many medics despise automated blood pressures. I'm most often told that the blood pressures of NIBP cuffs are unfailingly incorrect. It's a random number generator, right? I've always thought this was both funny and a perfect description of a paramedic's mindset. All of the rest of medical practice is wrong except for how I do it. Think about it. NIBP readings are used in doctors' offices, emergency departments, operating rooms, hospitals all over the world. Do you think that nobody confirmed that these things work? Some of the best overview information comes from two nursing documents. The first is an article in the journal Critical Care Nurse. Apparently nurses have the same concerns that medics continue to have. Quote, despite the widespread use of automated blood pressure monitors, clinicians continue to deliberate over the accuracy and reliability of automated NIBP devices compared to other methods of blood pressure determination, end quote. The article cites 9 studies that support NIBP accuracy within 5 millimeters of direct arterial pressure measurements. The article states, however, that there can be occasional random NIBP pressures that vary from the arterial pressure by more than 30 millimeters and cautions clinicians against making treatment decisions off a single NIBP reading. That's a pretty reasonable take. The Emergency Nurses Association wrote a clinical practice guideline regarding non-invasive blood pressure measurement way back in 2012. This document works through pertinent research to reach 3 main recommendations. The first one's the one that matters. Compare NIBP readings to auscultated blood pressure cuffs, but also use the right size cuff and follow manufacturer's guidelines. More specifically, they find that NIBP measurement is suitable for adult patients, patients with trauma and shock, and children. Evidence for NIBP use is weaker in the case of patients with chronic hypertension, AFib, pregnancy, and alternative cuff sites. AFib's an especially rough one. That varying filling time of the irregularity of AFib causes varying beat-to-beat pressures that's really confusing to an automated cuff. So if you're finding that the auto cuff is returning readings that are grossly different from your auscultated readings on a consistent basis, the cuff may not be the problem. But like any tool, automated blood pressure cuffs have limitations. They're usually a bit slower than I am. They can be confused by AFib and by arm movement or by arm flexing against the inflated cuff. Reported variations between auscultated blood pressures and automated blood pressures range from plus 5.4 to minus 11.2 millimeters of mercury in systolic blood pressures. You need the right cuff for the right patient. They can occasionally fire off a wildly wrong reading. NIBPs get confused by excessive road bumps. Finally, I have a suspicion that NIBP readings have more variation at the extremes of systolic pressures, like with very hypotensive or hypertensive readings. There are indeed studies, such as this one by Pereira in 2024, that caution against trusting NIBP in critically ill patients. Auscultated blood pressures have limitations as well. Blood pressures take 2 hands and 1 brain. No studies have established the range of variation between measured arterial pressure and the auscultated pressure reported by the new firefighter who inflated the cuff 4 times and has a look on his face like he's translating calculus to French in his head. Like with NIBPs, you need the right cuff to fit the patient. Finally, auscultated blood pressures have no automatic setting to result in a blood pressure reading every 10 minutes or 30 minutes or 3 minutes, whatever you want. So here's my opinion on NIBP. I think it's reasonable. Let me know what you think. Like with any tool, procedure, or medication, I need to balance the positives and negatives of NIBP readings against the pros and cons of manual blood pressures. When I'm tending to most patients, I check a manual blood pressure first. After all, it's pretty quick and simple in most cases. Because arm movement can screw with the blood pressure reading, the patient needs to be able to hold still, not flex against the cuff. It's not going to work on combative patients. They need to be unresponsive or cooperative and able to follow directions. Sometimes road noise or bumps can bounce the tubing, so I can stabilize the tubing like this. This one is an old phone cord style, so I can hook it to something stable like the counter or the pocket on the LifePak 15. Finally, the NIBP cuff needs to give a reading that's in the same ballpark as what I got with the manual cuff. If all that's true, I can set up the cycle time for something appropriate and get back to other work. Don't completely ignore the NIBP cuff. It can be a pretty helpful tool. Let me know what you think of all this. If you found any value at all from this video, please click the like and subscribe. One of the most helpful things you can do is share this content with someone you know. I'm Angry Bill. This is Pre-Hospital Wisdom. Until next time, stay safe.